Hi, everyone. My name is Dr. Brittany Dunn, and today we are going to talk about a brief hematology overview and some lab interpretation. We'll talk about how to interpret a complete blood count or a CBC, as you might come across that in practice. So let's get started. A little bit about me before we get into it. I am a FNP, but I practice mostly in pediatrics in the oncology population. So I work mostly with leukemia and lymphoma. So that's why a complete blood count is actually something that I do every single day. And it's pretty near and dear to my heart because it gives us a lot of really good information for my patients specifically. So I'll drop in a little bit of stories here and there, just things that I've seen in practice, but hopefully that helps the information stick a little bit better. Our objectives are pretty simple. We are hoping to obtain a working knowledge of some basic hematology and then become proficient in interpretation of a CBC or a complete blood count. All right. So these are some hematology basics. You are probably familiar with some of this, but basically this is a very basic depiction of hematopoiesis. So how do we get cells, basically? So we'll start up here with a blood stem cell. They differentiate into either your myeloid stem cell line or your lymphoid cell line. Myeloid line has the red blood cells, the platelets, and the myeloblast, which eventually become a type of white blood cell. The lymphoid cell line gives us lymphoblasts, which are a type of white blood cell. So this is just our starting point, and we'll kind of get into these a little bit more in the next few slides. All right, so white blood cells, these are also called leukocytes. There are 5 types that we'll look at, 2 basic categories that those 5 fit into. First, we have our granulocytes. These are cells that have granules, as you might guess, on their cytoplasm. And then we also have the agranulocytes. Obviously, they don't have granules on their cytoplasm. So that's how they're grouped. Within the granulocytes, we have our neutrophils, eosinophils, and basophils. And then the agranulocytes, we have lymphocytes and monocytes. So again, these come from those myeloblasts and lymphoblasts that we saw in the last slide. Granulocytes, they make up 50 to 70% of the white cells, and they have those granules on their cytoplasm. Those are the ones that we'll probably talk about a little bit more, especially the neutrophils. All right, for the neutrophils, these again are granulocytes. They are our primary defense against bacterial infections, and they work by phagocytosis. They progress in maturity in the order right here. So promyelocyte to myelocyte to metamyelocyte to bands and then segs. Now, in practice, you might hear the terminology like how many bands do they have? How many segs? Those are really just another name for neutrophils, baby neutrophils, basically. You might also hear the terminology of, oh, this patient has a left shift, meaning they have an increase in bands. And this is a pretty good indicator that they might have some sort of bacterial infection going on. Those are all just terminology that you might hear. If you have too many neutrophils, it's called neutrophilia. Too few would be neutropenia. Neutropenia, there's different grades of it. Severe would be less than 500, an absolute neutrophil count, or an ANC of less than 500. Those patients would be at very high risk for infection, could also be mild or moderate neutropenia as well. And we'll look at this a little bit more on a CBC, and hopefully it'll make a little bit more sense. But basically, when you see neutrophils, think bacterial infection and the body's ability to defend against. All right, next we have eosinophils. These are another type of our granulocytes, only 1 to 2% of our white cells. They are not responsive really to bacteria or viruses, not a ton of help in that category, but they are involved in the phagocytosis of antigen antibody complexes. So when you see eosinophils, think about those patients who are atopic. So the patients who have eczema, allergies, asthma, they might all have a higher eosinophil count. So eosinophilia is when there's a high eosinophil count. Again, those Conditions are listed here. Eosinopenia is a low eosinophil count. I don't feel like we see that quite as much. An eosinophil count can also help determine the severity of asthma. And you might hear these called EOs. Like, how many EOs does that patient have? That's what they're talking about. Next, we'll talk about basophils. These are another type of granulocyte. They're the third type. We don't have a ton of them, less than 3% of our white cells. These are also called mast cells, so you might have heard of that. Again, not super helpful in the way of bacteria or viruses, but they are helpful in the phagocytosis of antigen antibody complexes. So similar to eosinophils in that way. You'll have low basophils in an acute allergy attack, but you might have high basophil count if it's, if they've got allergic rhinitis, we're in pollen season. So I will say, I live in Alabama. Um, we have a ton of pollen, tons of trees and flowers and all kinds of things. So come April or late March, when I'm just looking at my patients' routine CBCs, I see a big jump in eosinophil count. So it's always interesting to say, like, have you noticed that you have a little bit of a runny nose lately? Do you have any allergy symptoms? And most of the time when they have that high eosinophil or basophil count, they'll say, yeah, actually, I do have a little bit of a tickle in my throat, or I do have a history of allergy symptoms. And that all makes sense, especially that time of year. We also see an increase in that during the fall because it's all those grasses are dying. So people who have seasonal allergies will have a little bit of increase in symptoms there. And you might even see that on their CBC. So just anecdotal, but kind of fun to look at. All right. So next, we're going to look at our agranulocytes. These are our lymphocytes. Two different types. We got our B cells and our T cell lymphocytes. These make up 25 to 35% of the white cells. They originate in the bone marrow, but then they'll differentiate in different lymphoid tissues. So you might see them in the thymus, spleen, lymph nodes, intestines. There are three types of T cells, T cell lymphocytes. You have your killer Ts, helper Ts, and regulatory T cells. B cells originate in the marrow, and these are precursors to what will become plasma cells that release immunoglobulins or antibodies. So with my patients, I primarily treat B cell acute lymphoblastic leukemia. So B cell ALL. That is like absolutely the most common thing that we see in pediatric oncology. So in this case, the issue is with the B cell in the marrow. Super interesting. So now we actually have some targeted therapies where we can target a protein that's on the B cell and select for those B cells, which again are the problematic ones in our patients a lot of times. And we can wipe out the B cells, which is great because you're wiping out their leukemia. But of course, the other side of the coin is then you're losing your B cells. So a lot of times we'll have to check these patients. We'll check their IgG, like immunoglobulin levels. And if they're low, a lot of times they'll need IVIG even after they've finished treatment. So IV immunoglobulins. And this is because their body can't make enough immunoglobulins if they don't have B cells. So it's a great therapy because we have much less systemic issues because we're not, giving them something systemically where it's killing all of their rapidly producing cells. We're giving them something targeted. But again, the other side of the coin is then we wipe out their B cells. So super interesting though, but lymphocytes are very important when they're working correctly. All right, and then the other agranulocyte is a monocyte. This is 4 to 6% of our white cells. Primary function is phagocytosis of bacteria and cellular debris. They kind of just chew it up. Anecdotally, so our patients who are in treatment for leukemia, if they're pancytopenic, meaning all of their cell lines are down, so their white cells, red cells, platelets are all down. If we see like a tiny little bit of monocytes, then we can feel reasonably comfortable that their bone marrow is picking back up. These are usually the first white cells that the body starts stimulating again. So we'll say, oh, they have a few monos, so maybe the rest of their white cells are going to be showing up soon. They're sort of the first responders. All right, this is a little bit busy, I know, but this is a grid from the Garzon et al. Burns pediatric textbook that we use in U632. But um, the main thing to remember is basically that you have to keep your patient in mind because lab values do differ with age. And hopefully your lab takes that into account wherever you work or wherever you're in clinical. But just understand that there's going to be some subtle differences based on age. So this is looking at a 12-month-old versus 4-year-old, 10-year-old, 21-year-old. There's some subtle differences, and that's okay. That's normal. You just need to know what's right for your patient's age. And remember, we are always treating a patient. We're not treating just a lab value. So I like to say, zoom out, take a step back. Does this lab value make any sense for this patient? Is there any reason that this value could be high or low? Is there possibly even a lab error? Do we need to get a duplicate lab to confirm our findings? So just pay attention. But basically, you can see the leukocytes do change in values throughout as patients age. All right, so we talked about white cells. Let's move on to talking about erythrocytes. So these are also called red blood cells, RBCs. If they are low, if we don't have enough, then we have anemia. Could be from a whole bunch of different reasons, but essentially low red cells equals anemia. The shape of our red cells is called an anucleated, so without a nucleus, biconcave disc. So think of a donut that's filled in the middle, but there's still a little bit of a depression there. It is such a smart shape because it allows for the red cells to pass through capillaries without being destroyed. And then it also allows for maximum surface area for gas exchange. So it's really just the ideal shape for what they need to do. Now, the issue comes in some people genetically have altered shaped red cells. A lot of people are familiar with sickle cell anemia. This is when those red cells that should be the nice biconcave disc are actually a sickle shape. So picture like a thumbnail crescent moon shape. These are not ideal because they hook onto each other, which causes pain. They don't allow for adequate gas exchange. They're brittle. So just not an ideal shape. There's also spherocytes, which are basically like picture a perfect beach ball, which again is not ideal because they don't slip between the capillaries very well. So not an ideal shape. That is actually a genetic condition called hereditary spherocytosis. That's something that you possibly could come across, but that would be an abnormality of the shape of the erythrocyte. All right, next thing to talk about, so erythropoietin. This is the hormone that's produced in the kidneys by the renal glomerular epithelial cells. It regulates the production of red cells. So basically, how many red cells do we need? Interestingly, if you remember the Lance Armstrong, like blood doping, the cyclist, back a few years ago, they were actually taking synthetic erythropoietin. They called it EPO. And it basically just stimulated more and more red cells to be produced. Which if you don't go overboard, it makes sense why your body would appreciate that because you're basically getting extra oxygen to all of your cells. If you're, a cyclist and you would benefit from that, it makes sense. But it could be problematic if you're producing too many red cells, then you could have issues there. So anyways, EPO, erythropoietin. And then if you look at the maturation cycle of an erythrocyte, they are pro-erythroblast to erythroblast to normoblast to reticulocyte to erythrocyte. And we'll talk about reticulocytes in a minute. All right, so reticulocytes. So these are immature red cells. They are elevated when the body is trying to stimulate the bone marrow to make more red cells. So it basically makes sense that your body's saying, hey, we need some more. We're a little anemic, so let's kick it into overdrive and produce some more. So if you see a high reticulocyte count in the setting of anemia, then that's the body compensating and doing what it should. That's a good sign. If you do not see a high reticulocyte count and the patient is anemic, that's a problem. It tells us that the body is not compensating well. So in practice, you could hear someone say they're anemic, but are they reticking? And they're asking, is their body trying to make more red cells? And if the answer is no, then we have an issue. All right, so continuing with erythrocytes, next we'll talk about hemoglobin. This is an oxygen carrying protein on the red cell. This is the value that in my practice we really pay more attention to than even the red cell count because we want to know like how efficiently are our patients getting oxygen to their cells. So we like to pay attention to hemoglobin. Normal adults should have 2 alpha and 2 beta polypeptide chains on their hemoglobin molecule. Issues arise from these chains if you have like alpha thalassemia, that means you have an issue with the alpha chain. Beta thalassemia, issues with the beta chains. There's other issues that you could see with the hemoglobin. So, example, hemoglobin S is when a patient has sickle cell disease. If there's too much hemoglobin F, then that's fetal hemoglobin. That could also be an issue. Um, just to have in the back of your mind, since I'm in pediatrics, I feel like I need to say it. So, newborns will have 70% of hemoglobin F, which again is that fetal hemoglobin. This should be gone by 12 months of age. So if they're like a 4-year-old and they still have some hemoglobin F, that should be referred to hematology. Um, Also in babies, you will see their hemoglobin levels drop shortly after birth until about 6 to 9 weeks of age. That's because they have increased blood volume demand, and then their newborn red cells just don't last as long. They have a short life cycle. Here are your normal adult hemoglobin levels. Men will be a little bit higher than women. One thing to keep in mind, women will be a little bit lower in pregnancy just because that physiological plasma expansion. So lower limit of normal would be closer to 10, and that would be relatively normal. So um, other things you might hear, so H and H, if someone says, what's their H and H? They're talking about their hemoglobin and hematocrit. So hematocrit is the percentage of volume of blood occupied by the red cells. It's a calculated formula. It typically is close to 3 times the amount of the hemoglobin. That's a very rough estimation, but there is an actual formula that you could calculate as well, which is the red cells times the MCV over 10. And we'll talk about MCV in a minute. So just to tie it up a little bit, anemia is a decrease of red cells, which is also a decrease of hemoglobin, which is also a decrease of hematocrit. They all kind of go hand in hand. You're going to have low hemoglobin if you have low red cells. That makes sense because you don't have enough hemoglobin to attach to a red cell. As far as when to transfuse, this is not something you're going to be dealing with in primary care, really, but just for knowledge sake. We typically at my practice will transfuse if a patient is under 8-ish for their hemoglobin, or there's an argument to be made if they have headaches, if they are tachycardic because their body is compensating, trying to push around whatever hemoglobin it's got, whatever oxygen it has, they could be tachycardic. If they have those issues, or if they are telling me I'm extremely fatigued, those are all reasons that you could transfuse a little sooner. But typically like 7-ish or 8, we will transfuse in my clinic. And obviously they would be pale if they are anemic. So anemic, typical symptoms, pallor, fatigue, headache, tachycardia. Those are all things that you would see with anemia. All right, continuing with erythrocytes, these are our red cell indices. So basically ways that we can describe our red cells. MCV is the mean corpuscular volume. So this is just the size of the average red cell. If it's low, if it's small, it's called microcytic. If the MCV is high, macrocytic. That means they're large red cells. The mean corpuscular hemoglobin, or MCH, is the amount of hemoglobin in each red cell. Basically how concentrated are the cells. So a low MCH is hypochromic, so not very saturated. High MCH, hyperchromic, a more saturated red cell. And then the MCHG is the mean corpuscular hemoglobin concentration. So this is an average concentration of hemoglobin in a certain amount of blood in comparison to its size. All right, so let's break it down a little bit. So erythrocytes, we're still talking about them, but on a CBC, which again is a complete blood count, what would you expect to see if you know that a patient has hypochromic microcytic anemia? I'll let you think about it for a sec. So hypochromic tells us that we have a low MCH, so not very concentrated, not very saturated cell. And then microcytic means small. So these are small, pale cells, basically. You would see this with iron deficiency anemia, is definitely the most common. And then also with your thalassemias, you would also see hypochromic microcytic anemia. And again, anemia meaning low red cells. All right, so what would a CBC show if a patient has hyperchromic macrocytic anemia? This would be a high MCH, so a concentrated or saturated cell that's large, but we don't have a whole bunch of red cells. So this can happen with B12 deficiency and folate deficiency. These would be your most common causes of a macrocytic anemia. All right, continuing with those indices, RDW is the red cell distribution width. So in this, we're basically saying how different are our red cells from one another? How variable is their size? So just like this picture, think you open an egg carton and you have 12 perfectly identical eggs. That would be a low variability, so a low RDW. But if you open it up and you have these eggs that are above, like where one is short, one is tall, one is a little fatter, one is speckled, whatever, more to do with the sizes. But if the variability is very high, then your RDW is high. So picture this when you're looking at RDWs. All right. So continuing on, this is just another depiction of some different variabilities you can see with erythrocytes. With the size variation, you have your normal for reference. Microcyte is small, macrocyte is large, obviously. And then your hemoglobin distribution, you have 4 degrees of hypochromia. So how severe is it? Polychromasia is that one that's a little bit bluish tinted. That's an increase of reticulocytes. And then shape variations, there are a whole bunch, which the lab would call these. And you could see these if you looked under a microscope, but these would be abnormal. A target cell is basically like an overinflated, pooled ring kind of thing. Spherocyte, again, is that sphere. You can see the sickle cell as well. All right, so moving on, we've got platelets. So platelets, most people are familiar with these. They are actually fragments of larger cells called megakaryocytes. If we didn't have them, we would just ooze blood from a paper cut forever. They actually help the body to clot. If you do not have enough platelets, that is called thrombocytopenia. Obviously, you are at risk for bleeding. In my clinic, we transfuse if platelets are less than 20,000. There's definitely an argument to do this higher if a patient is going to surgery or, is at risk for a brain bleed. All these kinds of things would be reasons to do it higher. But for our typical patients, we do it if they're less than 20,000. If you had a patient come in and their platelets are under 20,000, that would be cause for immediate referral to hematology and to send them to the ER. That would not be typical and not be normal. There's also something called idiopathic thrombocytopenia, which is essentially an autoimmune condition, and kids will get it, fairly commonly, I guess. But basically, it's when your red cells and your white cells are normal, but platelets are low. And that's called idiopathic thrombocytopenia. And they will look kind of like a leukemia kid would. So they'll have bruising, nosebleeds. The bruising can be pretty intense, and those patients would be directed to hematology and treated with steroids and IVIG. Again, not something you would treat in primary care, but if you noticed a low platelet count and could corroborate that with clinical status of bruising, bleeding, I would refer them immediately. Thrombocytosis is when you have too many platelets. This isn't very common. It's really not a problem unless the level is very high. It can happen after an infection. It would have to be pretty high for us to be concerned. And then the mean platelet volume is the MPV, and that is just the platelet size. Kind of like I mentioned before, just keep your patient in mind when you're looking at lab work. Values can vary based on so many different factors, based on age, like we talked about earlier, gender, pregnancy will affect things, medications can affect things, illness. My patients who have Down syndrome, a lot of times their hemoglobin and their red cells will be higher. Any patient with a cardiac history or sleep apnea, these could all be reasons for, or a smoker, they might have differences on their CBC. And also values can differ slightly from lab to lab. So the lab that we use, the normal value for platelets is 150,000 to 450,000. My sister-in-law recently had lab work and her platelets were like 444,000, which was slightly elevated for the lab that they were using. So I just had to tell her, this is totally normal. You are fine. So a big part of getting into practice is figuring out what's concerning, what's not concerning, what makes sense and what doesn't. And you'll get better at that. But I want you to be comfortable with the CBC so that you know when you need to emergently refer versus when can we say this is a normal variant. So, all right, let's go through a couple CBCs. This is the last thing that we'll get through. We're going to look at a CBC with differential. So differential meaning the lab takes the white blood cell count and then breaks it down into those white cell types. And it's differentiating out the white cells. I couldn't fit it all on one slide, so you'll see the differentiation on the next slide. But what jumps out to you here if you look at this? I'll give you just a sec. So this patient would be very, very concerning if you saw them in primary care. I pray that you would not see them in primary care. The white cell count is 0.09, and you can see these are all times 10 to the third power. So this is actually 90 if you move the decimal place over 3. So very, very low, like essentially no white blood cells. So they would be leukopenic. The red cells are very low as well, and the hemoglobin and hematocrit also low, so they are anemic. You can see here too how I talked about the hematocrit is roughly 3 times the hemoglobin. It's a little under that here, but close. The MCV, MCH are normal. So the red cells that this patient does have are normal in size and color. And then the MCHC is also normal. RDW, they're pretty uniform. The platelet count would be very concerning. This is a platelet count of 5,000, and normal is 140 to 440,000. So this patient is at extreme risk for a bleed as well as infection, and they are extremely anemic. So this would be a pretty sick patient. This is kind of typical for a leukemic patient. They would need blood and platelet here for sure. All right, so this is the differentiation of the white cells from the previous slide. Again, it was 0.09 or 90 white cells. So really the lab does not have a lot to work with here. So it fully makes sense that we don't have a lot of white cells to differentiate out. So it looks like of what they have, 0.01 are neutrophils. So that's the absolute neutrophil count. 0.08 is the absolute lymphocyte count. So the ANC and the ALC. And if you remember, the ANC is one that we keep a close eye on because it's a rough marker of how strong is the immune system to fight off bacterial infection at this time. And the answer for this patient is it is very weak, essentially no ability to fight off infection. So the ANC is 10, and just for reference, severe neutropenia is an ANC of less than 500 or 0.5. So very at risk for infection. This patient, I would tell them that they need to stay away from anyone who's ill, stay away from any crowds, no school. It's a pretty, it would be a pretty scary time of just trying to keep them away from people and protect their immune system because they don't have one right now. All right, let's do another one. So this patient is pretty similar to the previous. I'll let you look at it for a sec. So again, we are pancytopenic, meaning 3 cell lines are down. So our white blood cell count is really low at 0.16 or 160. So a little better than the previous patient, but still low. Red cell count is low, hemoglobin and hematocrit are low, MCV is fine. MCH is a little high, so maybe they're a little bit hyperchromic, a little more saturated red cells. MCHC, a little on the high side. And then the cells are not very differentiated, is what our RDW tells us. Low variability. Platelet count of 8,000 is very, very low. Very low. So this patient would need blood and platelets, and we would hope that their bone marrow would start producing some more cells real soon. And again, this is, their white count is 0.16. So this differential shows us of those white cells, what do we have going on? So the absolute neutrophil count, or ANC, is still essentially nothing, so 10. And the ALC is essentially nothing, 0.15. So again, this patient has really no white cells to speak of. So they would be at risk for infection. All right, this is our last one. This is a little closer to what you would see in primary care. The white cell count is a little on the low side, 3.67. Keep in mind, if your patient comes in and they say, I've had a sinus infection for 2 weeks, whatever, and you have a reason to do a CBC, you would likely see that their white cell count is high. So it could be like 15, which would make sense for fighting off an infection. But for this patient, white cell count's a tiny bit low. Red cells, hemoglobin, and hematocrit are all pretty normal, lower end of normal, but still normal. MCV and MCH are normal. MCHC, I mean, essentially normal. RDW, their variability is a little higher. And then their platelet count is normal, 372,000. So we can feel really good about that, although the platelets might be a tiny bit small based on the MPV. And then this is the differential. So the ANC, or the absolute neutrophil count, it's getting closer to where we want it. It's still lower than average. So this would be technically moderately neutropenic because this ANC is 0.94 or 940. The ALC, or the absolute lymphocyte count, is 1.89. It's normal. Absolute monocyte, absolute eosinophil, absolute basophil, those are all normal. So we can feel pretty good about those. Just to reiterate what I said before, just make sure you're always treating the patient and not just the lab work. And then it's good just to have an idea of what is normal and when you can reassure your patients, because anyone who comes in with any lab work that flags red, even if it's the slightest little, it's so close to normal, but technically just out of normal range, they're going to be worried. And so you need to be able to tell them what lab you're actually looking at, why you're looking at it, and if you should be concerned or not. All right, guys, that's really all I have for today. I really appreciate it. Hopefully you feel a little more comfortable with these topics and you can get into practice. And I would encourage you, as you're in clinical or at your job one day, go through the CBC and really think through, does this make sense? Or why would this patient, why would this patient who's a smoker have a higher hemoglobin? Why does that make sense? So just start thinking through those things and thinking critically. But thank you for your time. Here are my sources.